One thing I'd like to mention early on is we have a new member of PHAB, FAB, who's been appointed, and he is out of the country right now traveling, but will hopefully be at the October meeting. So that's a very good thing. And keep passing on the message. I know we're going to try and get a recruitment flyer out eventually, but word of mouth is great. So if you know people who would be good on the committee on the board that you think you can have a conversation with, then please do. And if it at all possible, please turn your cameras on when you can, and certainly when you're asking questions, that would help. And what else? The approval of August meeting minutes. So I'm going to ask if anybody has any edits or changes to those meeting minutes. No. Hearing none, is there a motion to accept the meeting minutes? Don't be shy. Anybody can.
Motion to. I hate to do it every time, but sure. I move.
Steve. Yay, I can count on you. And thanks, Libby. Okay, is there, can we vote? And we have to vote with a hand, I guess, because under the Brown Act, we have to do that. So in your reactions, you can thumbs up if you accept the minutes. Okay, 1, 2, 6, 7. Okay, great. Thank you. Minutes approved and accepted. And then we will move on.
And there's Carla, just if I might, just a reminder, so I just closed down the chat and folks can only chat to the host if they're having technical issues, but with the recommendations from our council around the Brown Act, if you can make any, in addition to the thumbs up, you can use verbal to let us know what's going on. So that way there's nothing sort of messaging privately, which is not allowed in a public meeting. So yeah, just so you know why that changed.
Yeah, it's hard to keep track of verbal, but it would work. We could try and do that. Thank you, Liz.
Barbie, I just wanted to say I had put abstain for my vote because I wasn't at the last meeting. So
right. Thank you, Barbie. Okay, a little awkward with this no chat business, but we'll get through it. Get used to that. There are 3 nominations for the HIV Health Services Planning Council. The candidates are Kashia Lynch, Christopher Kendrick Stafford, and Kelly Gluckman. They all, I hope you received their letters with a brief description of why they are, excuse me, asking to be on the Planning Council. They all seem pretty qualified. So we can, I guess, this is going to be interesting. I can start off asking if everybody would vote on all 3 of them. That would save time. If you up front, if you object to any one of them and want to vote no, could you please let me know right now? No. Can you let me know if you accept all 3 candidates? And I would, again, say a thumbs up, or if you want to say aye, that would be fine too. Okay, I'm getting 1, 2, 3, 4, 5, 6, 7. Great. I think. All right. Again, if you didn't vote, can you say abstain or no vote? No. Okay. All right. majority.
And Farla, another option is, should you choose to, is you can call roll for future votes if that's helpful for you.
Yeah, it's going to be a little slow going though, but thank you. I can try and do that. Okay, majority approves the candidates, and so we will pass that on to the HIV Planning Council. Thank you very much. All right, enough business of that sort. On to Public Health Division update. Dr. Kassirier has joined us as usual, and we appreciate her presence and are eager to listen to the update.
Hi, everyone. I know that Dr. Damiano did send a summary already, so it does include information on COVID and on monkeypox as well. So just to go over those real quick, with COVID, the numbers continue to go down. The major development there is that the FDA approved the bivalent booster doses. So that's what we're using in our clinics right now. And then for monkeypox, we are at 125 cases. The community that's still being most impacted is the MSM, or men who have sex with men, in the gay bisexual community. So we continue to do outreach, and we've worked really well with Pucci's Pharmacy that has done quite a bit of the vaccinations. We also are having vaccination clinics with the LGBTQ Center and a few other CBOs. I think those are the major, maybe there are other major change as far as vaccinations is that we are able, oops, did something change? Sorry.
Is that all right? Do you want it up?
Yeah, that's fine. That's fine. It's just that I thought that my computer was acting up again.
No.
And the report here shows the number of doses that have been provided in Sacramento County. So otherwise, apart from the fact that CDC did change the mode of administration of the vaccine, before we were giving it subcutaneous, and so 1 vial equaled 1 dose, but they changed that to allow for the intradermal, so it's within the very thin layer of skin that you have, but that allowed us to stretch our resources so that now we can get up to 5 doses from each vial, and so that has helped with being able to meet that need. Right now, it sounds like the demand for the vaccine has reduced. And so we are looking to the state to ask to find out if they want us to expand criteria, but it doesn't sound like that is going to happen soon because we have not seen it being spread widely to the general population. So I'll stop there and see if there are questions, or turn it back to you, Farla.
Are there any questions? And
I have a quick question.
Yeah.
Thanks, Dr. K. It looks like the 122 cases is cumulative. What's the month over month trend looking like?
Month over month, I would have to go back to, let me see if I can pull it up real quick. I don't know if I'm able to share it or not. Yeah, it's a bit difficult to share, but what we have seen a drop off, I think the easiest, I'll just email it out.
Thanks.
Looks like Phil has a question as well.
Yeah. Hey, Dr. Kassirier, thanks for the update. given that we are kind of in this heat wave right now, and these types of extreme weather events, are kind of increasing in frequency and severity, I'm wondering if we have any kind of formal mechanism to capture data on, heat-related illness and mortality. Our current kind of cooling center capacity is pretty geographically limited, and obviously our shelter capacity is disproportionately low for the population of people who live outside and are otherwise vulnerable to these extreme weather events. And I'm wondering if there's any kind of formal mechanism for capturing some of that data so that we can better respond.
We are monitoring using what we call syndromic surveillance, which is a system which basically pulls from the emergency room visits and looking for particular symptoms that people present with that might be heat related. From the results we have seen, there's a slight increase, not much. I think with the last couple of days, it's been like the max has been 18 people in the ED that have presented with ED related illnesses. No deaths reported thus far. We also, our EMS is also surveilling the ambulance services to find out if they are getting, or 911 call to find out if they're getting an increase in calls. One of the things we did last week was provide information about ways that people can keep safe, reminding people that they need to go indoors frequently if they have outdoor activities, and for organizers, if they can either postpone or cancel their events, or make sure that they have a plan in place to help people that might be experiencing heat exhaustion. So, and actually our Medical Reserve Corps was out at, I think it was Chalk It Up, where they had a cooling tent, and they also had misters and were providing water. So in that way, I think, and also the schools were provided with guidelines as to how they can make sure that the students are safe. And so far, I haven't heard anything at any adverse event at the school. So it sounds like they are taking heed. I know Sac State, for example, also reduced or changed the start of an event. For the homeless, I know that DHA opened several cooling centers. I don't know yet what the utilization was for that. And I don't know if we have anyone here from DHA and can speak to more details as to what they are doing for the homeless. But definitely there was a lot of activity to try and make sure that we did not have any adverse events.
Yeah, I really appreciate that. And if there would be any possibility that we could access some of that syndromic data, I'd be particularly interested. I know, right now both the city and the county have kind of ramped up their efforts to kind of criminalize and displace encampments along the parkway and displace people from the sidewalks. And I think a federal court halted some of those efforts due to the heat wave. And so I'm just kind of particularly concerned about that in the political context and everything else. So I would love more info if that's available.
Sure, I will. I know that they're still collecting the data, so it will be after the fact, probably after this week, that we'll be able to provide any data on that.
Really appreciate it.
Do we have any other questions? No. Okay. I also know that there are other organizations reaching out to the homeless and making sure that they have hydration and can access the cooling centers, not county, but nonprofits. Yeah.
I do have one last update. We were notified by the state that so far they have identified 2 flocks in Sacramento County that were had positive tests for avian flu. The good thing about the avian flu is so far they have not seen major transmission from birds to humans, but still we were required to do monitoring for the individuals that were in contact with those flocks. So far, nobody has developed symptoms. And so it's something that we continue to have on our radar in terms of watching out if we get additional reports.
Okay. Disconcerting, but thank you. Okay, so Dr. Damiano is preoccupied with many things, so she sent a primary health update that's available on the website, and it was sent to the members. If anybody has any questions, please let me know, and I can pass them on and get some answers. Otherwise, we'll move on. So Libby and Phil, did you want to just have any update? Is there anything that you'd like to let us know about with the working committee? What's going on? Could be very brief.
Yeah, I'm happy to give a quick update. It looks like, Phil, you're eating, so I don't want to put you on the spot. I do, however, have a new puppy who's going to be yipping at me, so I'm going to try to keep this really brief. In terms of the subcommittee, we have slowed down a little bit, and that's in part because we're waiting for some kind of major reports that are related to the work area. So again, this is the Correctional Health Working Committee. The Maze monitoring report, sorry, the Maze reports completed by 3 consultants, so sort of related to Maze consent decree and specific pieces of it, are due to come out this week. And then next week, the Board of Supervisors will be hosting a public hearing to review the findings of those reports. I believe we're also awaiting, if they haven't come out already, the routine Maze monitoring report. So these are 2 major sets of reports that are going to shed light on some of the questions that we've raised as a working committee and that are being talked about in the space. So I think with the release of these reports, we might pick up some momentum again as there's new information and want to engage with the supervisors and others on the way forward. Phil, I'm going to pass it off to you to close off, if that's all right.
Yeah, I actually don't have much to add. I think that encapsulates everything. So unless there's any other particular questions or concerns.
No, and I will receive an email when those materials are posted, so I will let everyone know. And that should be, as Libby said, mid-September, as far as I've heard. Okay, thank you very much. Look forward to all that information. It will be a lot to go through, I'm sure. All right, so now I'd like to thank Lori Miller for setting up this presentation by Ashley Zaru. Thank you very much for being here. We really appreciate it. And we will be very well educated about the overdose detection mapping project. And I'm sure there'll be a lot of discussion. So I will hand it over to Ashley.
And Ashley, do you want me to pull up your PowerPoint or do you want to pull it up directly? What's your preference?
I have it already pulled up. So if I'm just allowed to share screen, then I can do that. Yeah.
You should be able to. Let me know if you have issues.
Perfect. Okay. Thanks everyone for allowing me to be here. My name is Ashley Zaru and I'm the Drug Intelligence Officer for Central Valley, California, HIDA. HIDA stands for High Intensity Drug Trafficking Area, and our headquarters are based in Sacramento County. So I'm going to talk today a little bit about our OD map that we have as a HIDA across the country. So let me share my screen really quick. All right. I always have to switch the display view. There we go. Okay, so ODMAP stands for Overdose Detection Mapping Application Program. It was designed and created in 2017 by the, by the Washington-Baltimore HIDA. They're located in Washington, DC. It was created for public health, not for public safety. So I'm going to get into a little bit of the background and the history of ODMAP as well. So as we know, in 2021, there were over 108,000 overdose deaths throughout the United States. And the reason for that is fentanyl and meth. Those are our two main culprits right now. It's not a new epidemic. We know that it's been going on for a while, but now we have a little bit better tools to sort of see what's going on and where areas are being hit the hardest. So public health data can't be collected alone. It has to have other aspects that go with it to address the current epidemic. Same with public safety. We're not just getting our evidence and our data from our in-field personnel. We're getting it from all of these other sources. So one of these sources is our ODMAP. And what is ODMAP? It's basically an as near real-time surveillance. And I say as near real-time as possible because sometimes the overdoses are logged in 5 minutes. Sometimes they're logged in 5 weeks. It really just depends on the agency that's inputting the data. So it supports public safety and public health efforts to mobilize essentially an immediate response to overdose events. We want to deploy the resources as quickly as possible to areas that are being hit the hardest with overdoses. And like it shows on this slide, you can use it on your computer, your tablet, or your phone. It's mobile friendly. So we are currently in all 50 states, including the District of including the District of Columbia and Puerto Rico. We have about 30,000 agencies that currently use it. And this national map shows all of the different agencies that do use it. So Florida has 100% ODMAP implementation. Michigan has 100% ODMAP implementation. There are about 12 states that have 100%. Every agency is on board. They use ODMAP every single day for every single overdose. So some of our goals are, again, to provide that near real-time surveillance of where these suspected overdoses are happening. We want to provide participating agencies with data to identify where they're happening. And like I said before, deploy those resources to the areas that are being hit the hardest. One way to do that is with spike alerts, which I'll get into a little bit later. And it also, being part of a federal program, for me, it helps with strategies and collecting data on which drugs we may be seeing more come over the border. So this is a little bit on more in-depth ODMAP. So you're allowed to have ODMAP access if you're a federal, state, or local or tribal law enforcement agency or any sort of criminal justice personnel. So we even include medical examiners and coroners in that as well. And then any public health personnel. So the Department of Public Health can have it. Department of Health and Human Services can utilize it as well. Licensed first responders, so fire and EMS, we really try to hit those agencies the hardest because they are the ones that respond the most to the overdoses that are happening. And then any hospital with an emergency department also can have access and input overdoses onto ODMAP. You have to sign a participation agreement in order to gain access to it. And that outlines all of ODMAP's, policies and procedures, MOUs, no PII information is shared, things like that. So you have to fill out a application. Your application has to get approved. And then once you're approved, you sign the participation agreement and then you gain access. It takes about a day for access to be approved. So what data is collected by ODMAP? Well, each entry must include the date and time of where the overdose happened, the location, the outcome, so the fatality, if it was fatal or non-fatal, and then whether naloxone was administered. And we do have a section on naloxone where you can check how many units were administered as well. You can add as an agency additional information, so that includes a suspected drug, the demographics such as the gender, And then whether there were multiple victims or if it was just one victim, and then whether that victim or victims was transported to the hospital. So like I said, it can be entered in 3 ways. It can be entered manually through the website, and that's just, you know, the infield personnel going on to ODMAP, filling out this whole section right here, and then clicking send, and it submits it right onto the national map. You can also do an application programming interface, which is called an API, and that pulls the information from the agency's computer aided dispatch system and automatically populates it onto ODMAP. So it cuts out having to put in all of this manually. And then OD form, that's just specifically for some different law enforcement agencies. I haven't heard of it so far in the Central Valley of California, but there are definitely agencies that utilize it. So this is a little bit more about the API. ODMAP itself is free. You can go on, you can, you know, fill out the application, you get your access, and you can start submitting entries manually the day you gain access. The API is different. So it's something that you have to pay for, basically. It's utilized through different businesses that create these APIs for ODMAP. And so you would essentially have to pay that company in order to get their software for ODMAP. So we've seen that range from anywhere from, you know, $1,000 to $12,000 to free. There is one company, Biospatial, that does ODMAP API for free. And they specifically work with a lot of our EMS agencies in California and across the country. So the API is a little bit confusing, and I'm not going to get into it a lot here, but it's easier for there to be no duplicates. There is a software that ODMAP has that takes out the duplicates, but it just kind of also cuts that middleman out as well. And then HIPAA. ODMAP doesn't violate any HIPAA restrictions. Like I said, we don't collect any PHI. So we're not putting in, you know, the name of the victim. We're not putting in the birthday. We're not putting in their exact address, things like that. ODMAP is not a collection point for victim information. It's really just a map of a dot with the overdose on it. The ODMAP zoom function is restricted to a zoom level of 15. So I'll show you that when we get to the other slides. And then ODMAP is, like I said, not meant for the general public or the media. We don't alert the general public that this is, you know, a program that we have. We don't let the media know. We restrict access to images. And even when I do presentations such as this one and it's being recorded, I'm not allowed to actually go onto the ODMAP website and do a demonstration. It's all dummy data that we have put together for presentations like this. And like I said, it's not intended to be a system of record. So these are a little bit of the tools and what ODMAP can do. This is what the national map looks like. So when you gain access to ODMAP and you click on this part up here, national map beta, this is what will pop up and this is what you will see. Like I said before, this is dummy data that the Washington-Baltimore HIDA put together for us to use in presentations. And all of the diamond points are fatal overdoses, and then all of the dots are non-fatal overdoses. And it will tell you down here, you know, there were, sorry about that. There were, you know, over 4,000, gosh. There we go. There were over 4,000, you know, overdoses for this 3-year period down here in this time range. And then, you know, there were over 2,000 fatals for this time range as well. You can filter down the information pretty narrowly on using these filters. You can go by state, then by county, you can go by zip code. You can have a 24-hour period. You can have, like this one shows a 3-year period. It just depends on what type of data you want to look at. You can also filter it by drug, by agency that inputs the information. You can do a heat map. You can filter it down even if you wanted to see all of the overdoses that happened on a every Wednesday of, the past 4 years or however, it gets very, very narrow. Or you can have it pretty broad and generalized, such as this one, where it's 3-year period. There's no other filters on there. And this is what you get for that 3-year period. Oh, I don't know why it's doing that. So as I pointed out, you can have the 24-hour summary statistics. So if you wanted to just do a 24-hour period for California, this section right here would change. So it wouldn't necessarily say 4,900. It might say for the past 24 hours, there's been, 400 overdoses, things like that. And then, like I said, the built-in filters. So you can do dates, you can do location and type of drug. Sometimes agencies who aren't putting in the suspected drug, those overdoses will not show up if you're just filtering it by drug. So that's kind of something that we're trying to work on right now. And then you have built-in charts up here. You can click on, so the outcome, like I said, you can do day and month, or you can also do the county and the line comparison. So like I said, if you wanted to see all of the random Wednesdays for the past 3 years, you could see that as well. And, if you wanted to see only fentanyl, you could do that. So like I said, there's filters, heat maps, and charts that you can automatically download from ODMap, which is very beneficial instead of having to go in yourself and, pick and pull the information that you want. We do provide spike alerts. So if you wanted to see Sacramento County and you say for every 24-hour period, I want to be alerted if there's more than, like, let's say your threshold is 7 overdoses. I want to be alerted if there's more than 7 overdoses happening in Sacramento County for a 24-hour period. You can set that up and it will let you know each time there are more than 7 overdoses in Sacramento County. So I have mine set up for all of our 15 counties within our HIDA across the Central Valley. And I'm constantly getting emails, or you can do text, but emails are just more convenient. Constantly getting emails saying, Kern County's in a spike alert. There's been more than, 10 overdoses in this 24-hour period. So we had one for Sacramento County this past weekend. There were 41 overdoses this weekend in Sacramento County. And it'll let you know when the spike alert has ended. So if the spike alert happens on a Monday and the spike alert doesn't end until Friday, that just means, that more than 7 or 10 or whatever your threshold is, more than that amount of people have been overdosing on a daily basis. And you can add that in for fire and EMS. You can also add that in for, I believe, certain drug types as well. So if you want to see the fentanyl spike alerts, you can do that. And then, like I said, multiple agencies are providing data for different areas. So for right now, California currently has the California Ems Authority on board, and they have started uploading overdoses, and they backlogged from 2020. They started with their overdoses from 2020, and they are currently uploading overdoses to today, and they're doing it in pretty real time as possible. It's about 6-hour delay from when they get the overdose to when it's being input into ODMap, but it's more information than we've had before. They work with 35 counties across California, and one of them is Sacramento County EMS. So we're now getting spike alerts and overdose information for Sacramento County, whereas before in Sacramento County, we only had Folsom Fire and Folsom PD that were entering data into ODMap, and obviously they just concentrate on Folsom, so we weren't getting a whole lot of information there. Now we are, and we're seeing unfortunately a huge growth in overdoses across not only Sacramento County, but the entire state as well, with having KEMSA on board. So this is a little bit more into the spike alerts that I was just talking about. You'd get an email like this one that says for Henrico, Virginia. You can set your threshold number if you want to know. Let's say you want to know if there's been 3 or more overdoses for Sacramento County. You can do that. If you want to do 10, you can do that as well. And it will also tell you down here, it will say the spike alert was requested by so-and-so agency. When you are submitting your application in for ODMap, and you have to put your agency, this will obviously be changed to, Department of Public Health has requested this spike alert. Duplicate entry notification. So the Washington-Baltimore HIDA has a pretty good software that targets duplicate information and takes out the second overdose. So let's say there's, fire, EMS, and law enforcement are all at one scene of an overdose, and, fire input one manual entry into OD map, and, EMS did an API, and then law enforcement also did a manual entry. It will recognize the overdose within 285 feet and 1 hour after submitting the overdose, and it will take out the two that do not have the API. So what that means is there's no duplicate overdoses unless there's multiple victims at the scene, and in which case you would check the box on the OD map manual entry, or the API would recognize it, and it would let them know that, hey, there's been, 4 overdoses at this one scene. There was a house party or whatever the case may be. So it will say, submit to this location the duplicate, or don't submit, return to the main page because this overdose has already been logged into OD map. If you guys have any questions, feel free to reach out to me. This is my email right here. Whoa. This is my email right there. I'll put it back on the screen. We do have an OD map coordinator, Marquis Johnson, who works out of the Washington-Baltimore HIDA, along with the OD map program manager, name's Ali Burrell. They both work in Washington, DC, and their main focus is OD map. I'm the drug intelligence officer for Central Valley, California, and I handle 15 counties within the Central Valley, sort of promoting OD map, doing a lot of overdose response strategy and awareness and prevention, along with my partner, Janeri Garcia, who's the public health analyst. She unfortunately is training this week, so she couldn't make this meeting. But yeah, that's a little bit about OD map. It's a lot. I'm gonna stop sharing my screen. It's a lot to take in. And we've really been trying to push it for Sacramento County, just because now Sacramento County EMS has it, and fire really needs to utilize it along with the other private EMS agencies because of the fact that they're going to the overdoses more often than law enforcement. So does anybody have any questions? I'm sure there are.
I have a couple of questions.
Mhm.
Thank you so much for the presentation. I'm very curious. Actually, I think your earlier slide with the 4 entities that are part of this, could you just go over them? I don't think we identified all of them.
Yeah, so I'll put it back up. Let me just find it really quick. So it's date and time.
No, the like EMS and fire and police.
Like who is able
are
to
the
have
4?
access to it.
Yeah.
Let me find that slide. So it's fire, EMS, law enforcement, public health, and why can't I find that slide? Hold on, I'll share my screen again, and you can just write it down. Okay, so yeah, federal, state, local, and tribal. And like I said, law enforcement, public health, fire, EMS, and then hospitals with emergency departments. We have gotten some questions from other counties regarding if treatment centers are allowed to use it, and I don't believe they are unless they sign very specific guidelines that have to be written up by the Washington-Baltimore HIDA, because treatment centers are more of a public entity and the public's not allowed to have access to it. There's a lot of red tape that they would have to go through in order to have access to it.
Do you know how the data is being used, especially by the entities who are reporting it as well as others?
So for like fire and EMS, they don't really use the data. They're essentially the ones that are giving us the data. Law enforcement, it's really good for situational awareness. If you have undercover officers that need to know, hey, this homeless camp is having a lot of overdoses, or this one street in Sacramento County is having a lot of overdoses. Maybe there's a dealer over there, or that maybe there's a big supply. You know, it's really good for law enforcement situational awareness. For myself, being a drug intelligence officer with HIDA through the Office of National Drug Control Policy, we use a lot of the data and the numbers to report to the Office of National Drug Control Policy. You know, hey, Central Valley, California, these 15 counties that we currently have are seeing major issues with fentanyl in the community, and or maybe meth, or, you know, juveniles are overdosing, things like that. It gives us a little bit better of a look at what's happening on the ground instead of getting the intelligence directly from law enforcement or public health. We're able to just sort of go in there and see it a little easier.
Okay, let me go to Lori and then Steve.
Sorry, Steve, I know you were first, but my question, comment kind of relates to your question, Farla. The way the Department of Health Services wants to utilize this data is to identify, you know, any trends in the community, demographics, zip code areas, so that we understand kind of the need to respond, and being able to put like prevention and treatment resources within those particular communities that are being impacted the most. So those are some ways that we would like to use this data moving forward.
Yeah, it kind of just depends on how the agency chooses to utilize the data. And, you know, Lori, that's a great example. I know that, you know, like I just gave for law enforcement, it's situational awareness. So it really just depends on how the agency would want to utilize the data.
So Lori, let me follow up. Thank you. So do we have a mechanism for urgent response to seeing like a spike in overdoses in a specific area? And I know there's no law enforcement here. That would be law enforcement for identifying the drug dealers, but it would be mostly for alerting the population that something's going on, and whether it's you know, tainted drugs that are being distributed, or whatever, to get that information out quickly.
Can I respond to that?
Yeah.
One way we do that is actually getting information out to CBOs that provide services to the affected community. Especially, we've been able to do this when there's a suspect that there's a tainted product out there. A very good example of that is when we got the fake pills that actually ended up being fentanyl, and they were being sold as something else. And the only way that we actually got alerted about it is that one of the ED doctors sensed that, you know, they were getting a lot more overdoses than they usually do, and thought to call public health. And that's when the whole system got alerted. I think having this system in place will help us a lot more in seeing if there are patterns that are coming up. And also, of course, is backup to if we do get calls from providers in the community that feel like something's not right. We have more data that we can look at and in real time know if something is going on. And as Lori also pointed out, one of the ways that we can use it for public health is to identify trends and patterns, and also demographics of communities that are being impacted, so that will help us in being able to hopefully get the correct messages out to the right people, and also in situations where we feel that we need to engage the DEA, do that as well, which is what we did with the fake fentanyl pills.
And how fast can we respond?
as fast as we get the message.
Okay, all right, so you can, are you actually using this now, the system?
No, we are not. And my hope is that we will be able to, as I mentioned, I think with what happened in 2015, we were very fortunate that there was a very astute ED doctor who thought to call us. And also it so happened that UC Davis was able to test for fentanyl with the strips that they were using. Otherwise, I think it would have taken us a lot longer. The other problem we've had in public health is usually we've depended on data that we get at the end of the year from either death reports or from the I've forgotten, they changed the name now, but they get all the information on hospital admissions. But it takes a while to get that information, so it's always after the fact. So this would be a way for us to be able to get more real-time information.
Okay, I'll hold my other questions. Steve, sorry to delay getting to your questions, but here you go.
No problem. I just want to know if there's a map, Sacramento recent or whatever, we can take a look at, see what it looks like Sacramento County. And the question is, were there any surprises that came up as a result of being able to see this geographic mapping?
Yeah, so unfortunately, because this meeting's being recorded, I'm not allowed to go onto the national map and do a demonstration for you guys because of, HIPAA and things like that. And for Sacramento County, I think it's been quite interesting to see all of the meth overdoses that we've been having this year. Fentanyl is so big right now. It's such a buzzword, and it's so important for teens, especially, to understand, one pill can kill and all of that. But also then you have methamphetamine, and that seems to be killing the population 45 and above, a lot higher than fentanyl. So seeing kind of that contrast has been really interesting for us as well, at least for my federal program that I'm a part of. Yeah.
Thank you. Phil, you had a question?
Yeah, thanks. So kind of building on our previous conversation, in terms of kind of public health response for these things and coordinating with the community-based organizations. So I know it's not publicly available. Are there like read-only versions that or some sort of digest that could be published that can be shared with community-based organizations, or would the mechanism just be public health entity, EMS entity, whatever gets a spike alert, and then they have communication mechanisms with relevant organizations? Or is there a way that these community-based organizations can collaborate in this process?
So that's a great question. Off the top of my head, I know that since the public does not have access to it, community-based organizations, kind of like what I said about treatment centers, such as drug-free coalitions, they would have to write a really good letter to Washington, Baltimore, HIDA explaining why they would like it. And then they would have to go through a lot of red tape in order to get access to it. The Washington, Baltimore, HIDA likes to safeguard the information, especially for, the victims' privacy and things like that. I know that we said we don't collect any PHI, but if you have a rural area and there's one house on a street and there's an overdose there, and you zoom in, you're going to know, oh, that's my, I know this person. That's a one-off situation. But just for things like that, we don't allow the public to have access to it. That being said, I know that some coalitions across the country have been allowed to have access to it. They're, community organizations, but it's only a certain amount of people are allowed access on to the site, and they're not allowed to, same for me, they're not allowed to share the demonstration when the meeting's being recorded. They're not allowed to share it in public spaces. They're allowed to take the data that they get and then sort of put it into their own data and formulate their own conclusions from it. So it's still a new thing. It's only been around for 5 years. So there's definitely a lot of tweaking that needs to happen, but it's still good, I think, as it is right now in order for us to use it.
So Phil, for Sacramento County, the way I envision this happening is having representatives from public health and Department of Health Services to have access to the system. And then we would like to report out, like Ashley mentioned, in our ways, letting community-based organizations know, or the community know kind of generally where we're seeing trends, where we're seeing, you know, the most impact, what we'd like to do to address these issues. And we would do that through forums such as this one, you know, advisory boards, our coalition meetings, you know, and other related meetings that would interface kind of with the work that we all do. So that's kind of the plan for Sacramento County, and getting the word out to the community, even though not everyone can have access to the actual system.
I think that makes a ton of sense, and I understand those restrictions and those concerns. This sounds like such an incredible tool, and I hope that we can kind of integrate a lot of these community partners that are, you know, on the front lines witnessing this, and also often mobilizing the grassroots kind of efforts to respond to these things. And then one other kind of concern that this raised for me, I mean, you just mentioned kind of how, you know, there's no PHI collected, but some of this geographic information can, you know, draw attention to certain people. And I think it's a really valuable, you know, public health intervention tool. I think my concern is with the like law enforcement agencies utilizing this information in, you know, for instance, the situation you mentioned in a rural area, and there's one house that has these reports. And then if that, you know, obviously these reports are filed without the person's consent, if that then draws additional law enforcement attention to a particular area, then, you know, that report is potentially putting, you know, making those people vulnerable to criminalization. And just thinking kind of in terms of, you know, the Good Samaritan laws we have, where, you know, you call 911 for an overdose, and we're supposed to be making people feel confident in calling 911 and not having them hesitate to call 911 due to legal action. And I'm just concerned that law enforcement utilization of this data could undermine those efforts and, you know, decrease the utilization of our emergency services for overdoses if people become concerned that they're going to be making themselves and their communities vulnerable to criminal enforcement. So,
Right. So the goal of law enforcement that does have access to OD map is to not arrest the people that are overdosing and to not have any criminal complications come to them. It's really more for, and this is what I've been told by a lot of law enforcement agencies that utilize it, it's really more for their situational awareness. They need to know the different areas that they're sending patrol, undercover officers to, for them essentially more to help, and for the undercover officers to see where these dealers are coming from. Where are they? Where are their hotspots that they're able to identify, and go and arrest the dealers and then find the suppliers, and not necessarily arrest, you know, the users. That's not the goal of law enforcement. They really just want to crack down on, you know, finding the dealers. Are they connected to a bigger drug trafficking organization that's maybe coming in from Mexico? You know, is that where they're getting their drugs? Things like that. It's able to show them a little bit easier where these hotspot areas are happening. I've never heard of a law enforcement agency going in and arresting a user in a rural area because they saw it on, you know, OD map. That's never happened. I've never heard of it across the country happening. It's not the goal of law enforcement. They have other bigger issues to worry about, like drug trafficking organizations that have infiltrated California and the rest of the country. They're not concerned with the user who needs to get help and maybe needs to go seek treatment for it. So I hope that kind of answered your question a little bit. And I honestly don't remember the second part of your question.
no, I think that addressed most of it. I think, you know, for the, you know, the each individual call, you know, it might not have that effect, but just if, you know, if communities are noticing a pattern where, okay, we called 911, and the ambulance came, and now all of a sudden there's a lot more law enforcement activity and things like that that might have a chilling effect on kind of getting these public health interventions and the emergency medical response that's necessary. What I'm getting at, are there models that you're aware of that don't have the law enforcement component? Like, are there counties that are doing it that don't have the law enforcement component?
No, there's across the country, there are, I mean, of the 30,000 agencies that are using ODMAP, there's probably 10,000 that are law enforcement across the country. I know California has really good Samaritan laws in place to protect, you know, people who are calling 911 and who are maybe assisting with Narcan if they see someone overdosing on the street to protect them. So I've never heard of that being an issue. It's never been raised in any of the ODMAP meetings that I've had, you know, with our national team. So I don't know if that has ever been an issue. Not to say that it probably hasn't happened, but yeah, I haven't heard of anything happening like that.
Yeah, I hope that's hopefully something we can kind of address with our like community stakeholder meetings in the future as we kind of roll this out.
Like I know for Folsom Police, they use it, they sort of use it in tandem with Folsom Fire. So if Folsom Fire gets to the overdose first, then they will input the overdose into ODMAP. If Folsom PD gets there first, then they'll input into ODMAP. But they're not, honestly, they're not really looking at it as we have to go in and, you know, figure out the person who called 911 because that's protected information. That's only going to be, you know, found out unless you write an MOU to the Washington-Baltimore HIDA and, you know, you have a really good reason for wanting to know that information. So there's a lot of things that would have to be put, you would have to essentially go through in order to get that information. It's not readily accessible within ODMAP itself.
Phil, I will certainly make sure that we get stakeholder engagement around these concerns. I documented your statements around this and your concerns. So as we move forward to kind of have more discussions around this and roll this out in the various forums, I will make sure that there is stakeholder communication and discussion around that.
Awesome. Thanks so much, Lori.
Sure.
Wonderful. Thank you. Rich?
Yeah, so Ashley, just from my notes, I know it's new that we're getting actual Sacramento County data. Who are we? I know it's Folsom Fire, Folsom Police. What are the other agencies that are reporting on Sacramento County data?
So with Sacramento County reporting, it's Folsom Fire, Folsom Police, and then Sacramento County EMS because they have connections to the California Ems Authority. And whenever they log an overdose into their computer-aided dispatch system, the API biospatial that CHEMSA has takes that information from the county EMS and populates it into ODMAP. Other than that, there are no other agencies in Sacramento County that are utilizing it. Citrus Heights PD has an account. I've met with them and they just aren't really into it, which is, I mean, it's fine. It's not really that important for them. And yeah, that's about it. It's very, very low agency utilization in Sacramento County. That's why I'm pushing for public health.
So when you're talking about EMS, it's not necessarily fire, it's just the ambulance companies?
Correct.
Okay, so those would be the ones reporting to the state, which would then the state would then be able to report the data. Okay, thank you.
Correct. Yeah.
So theoretically, well, let me ask you, do you know the resistance of various agencies or in the county?
Like I don't have like a number off my head.
But just why these various agencies that could be participating who aren't, what rationale is it? What objections do they have to it?
Yeah, so I've met with the medical director for Sacramento Fire and EMS, and when he met with his stakeholders, they were kind of like, we don't really feel like this is valuable to us. They don't see the effect and benefit that it has for everyone else. So that was kind of something that I have been slowly working on them with. And a lot of pushback too is also, you know, if an agency has to do manual entry, they may not have the staffing to accommodate that. Even though it only takes about 30 seconds to input an overdose into ODMAP, they still may not want to use their resources for the manual entry. On the other hand, there's the API, but the API is, you know, could be a couple $1,000s that the agency just doesn't have to put towards a new program. Law enforcement, sometimes they don't want to train their officers on a new tool. Same with fire and EMS. They don't want to utilize their limited resources for training purposes. So we've kind of heard every excuse in the book at this point. I understand completely every single one because we're in such unprecedented times and because staffing is so short just across the board. A lot of agencies just don't want to bring on something new for those reasons.
But Ashley, now that the California EMS is on board, whereas before when we were getting some resistance, they were not, and it was more of a resource issue and double data entry issue and the fear that there was a cost involved in it. But now that the California EMS Authority is supportive of it, I'm assuming that a lot of the resistance will be minimized.
That's the hope. So far, it's been the same. Unfortunately, we're able to show a lot more data collected for California, but because the California EMS Authority only supports EMS, it's been hard for fire and for public health and human services to sort of hop on board with it as well.
So we plan on having some follow-up meetings with fire and with individuals that had some resistance in the beginning, and just to, you know, indicate that, you know, public health and Department of Health Services, you know, is very supportive of it, and then give the benefit of having this here in Sacramento County.
Yeah, I think that'll be really beneficial. I mean, once they hear that, you know, one agency locally to them is on board, they're a little bit more willing to hop on as well, because the California EMS Authority is the entire state. There's a lot of politics that go into that. They're state run, they're state funded. So sometimes they just don't want to be a part of something like that as well. But I'm hoping that, you know, now that we have them and we're able to show Sacramento County EMS is essentially giving us data now, that fire will sort of tag along to that.
So there was a question that came in through me. How is this program funded and what legislation created the need for this program?
I don't know what legislation created the need for this program. It was created back in 2017 through the Washington-Baltimore HIDA, and that was way before I joined the HIDA program. And I know that there is legislation written regarding ODMAP and HIPAA violations, and sort of the data that's collected and how it's used. And then what was the second part of that question?
So how is the program funded and what legislation created the need for the program?
So the Washington-Baltimore HIDA gets their fund along with every single HIDA across, there's 33 HIDAs across the country. We are all funded through the Office of the National Drug Control Policy, which is part of the Executive Office of the President. So we get all of our funding from the federal government. We're not an agency or a department or a business. We are literally just a federally funded drug program. And Washington-Baltimore gets their funds from there set aside specifically for ODMAP. Since they created it, they're in charge of it. They have all the software and all the people from their HIDA that run it and put everything together.
So you mentioned that some of the software, the API, is freely available by one organization or a company?
So Biospatial does their API for free for EMS agencies, and that's how the California EMS Authority was able to get the API, because they went through Biospatial. It was free for them. And then ODMAP itself, just submitting an application and having access and manual entry is all free as well. It's just the API. It depends on which company you go through. There's First Watch, there's Image Trend, there's Biospatial. It just depends on which one fits for your specific agency.
Okay, so currently, where are the gaps in data from the county? You said Folsom Fire and EMS is on board. The city of Sacramento isn't, I understand, and Citrus Heights is not interested. Is that the police department?
Yeah, Citrus Heights PD, they have an account and they're able to go in and look at, the data and everything, but they're not uploading any overdoses. And they're also, I don't believe, even really utilizing it for any sort of situational awareness because of the fact that the data points for Sacramento County are so low. It's not really providing them any specific data that they would be able to use, until we got Sacramento County EMS on board. There was really nothing for other people to go off of. So now that we have Sacramento County EMS through the, California EMS Authority, we have a little bit more data to go off of. But that's literally it.
And we plan on reaching out to these other law enforcement agencies, Farla, because PD and Sheriff's Office do go out on calls, but they're also partners with some of our behavioral health programs. And so there is a benefit to them. And the folks that may have been talked to previously may not realize the benefit. So we may have been talking to the wrong people, but there certainly is in the programs where we have partnerships with law enforcement. And so we will be following up with them and trying to get them on board as well.
Great. I may come back to this, but I see Barbie has a question or a comment.
Yes, I'm sorry, I don't have camera because I'm driving right now. So I was Sacramento Metropolitan Fire's EMS chief up until June of this year. And so I'm very curious, and this might be more a question for Dr. Kassirier if she's still on. So what data elements are actually being utilized by ODMAP? If they're getting the information from SCEMSA, that's all just the information that's probably being exported from all of the EMS providers in the county on a daily basis through the EPCR system. So we're all using the same data elements, and it doesn't get that granular as to the type of an overdose. So all we have in that NEMSIS, the National Emergency Medical Services Information System, is the ability to indicate that there was an overdose. But that could be anything from an overdose on a household medication to a meth overdose and everything in between. So I'm curious how SCEMSA is actually getting the information to ODMAP. Is somebody manually then taking a look at all of those overdose patient care reports to get that information into ODMAP?
No, they're taking it directly from the in-person or the in-field personnel EMS that are putting it into the CAD system. And then the API that KEMSA has through Biospatial is pulling that information and populating it onto ODMAP. So they're only doing the 4 required fields, which are date and time, location, naloxone administration, and whether it was a fatal or non-fatal. They're not inputting suspected drug or any other information.
So when you're talking about CAD, that's really the dispatch system, which SCEMSA doesn't typically have access to. So that's where I guess I'm getting a little bit confused on how.
Yeah, we're not entirely sure either. We're meeting with KEMSA at the end of this month to get a little bit more information with how exactly they are pulling the information from the infield personnel. All we know is that they have an API with Biospatial. The API is pulling it from the EMS, either CAD or records management system, and then populating it onto ODMAP. So
it won't be coming from CAD. We don't record that we've given medication in CAD. That's a dispatch system. So it's probably coming from the patient care reports. CAD feeds some of that information in there, but if you're getting whether or not Narcan was administered, it's not coming from CAD.
Yeah, so we'll be getting more info at the end of this month when we meet with KEMSA directly to go over all of the details, because it happened so fast. It was literally 6 emails between the KEMSA director and Washington Baltimore HIDA trying to get ODMAP, and then all of a sudden the next day there were all of these new populations on ODMAP for California. So they have not ironed out the details. We don't even really know where they're getting or how they're getting the infield personnel to submit the overdoses onto ODMAP. So at the end of this month, once we all HIDA in California meets with them, then we'll have a better understanding of where they're getting their information from.
Sounds good. Thank you.
So again, I'm not clear on the resistance from these other entities. I would imagine, as Lori, you mentioned, you're going to reach out to them. So for Sac County right now, is there a funding issue with this, or are you using it?
I don't provide any funds
No,
for.
this is for Lori.
Okay.
No, yeah, we're not currently using it because it hadn't been, fully implemented or rolled out here in our county. We've been trying to advocate for it for a couple of years now, given some of the resistance of the folks that were needing to enter the data so that we would, have a clearer picture. Now that we have more support around it, and certainly, Department of Health Services and Public Health Behavioral Health are on board, we plan on having some additional community engagement meetings around this to get more law enforcement who would input the data to buy into this, so that we can have the most data available to us. Currently, the data that I get that is different from what has been expressed today is through the coroner's office. And so I do get minimal data on, meth and fentanyl overdoses here in this county in a certain time frame. And I do get demographics on whether it's male or female, but no other additional data at this time. And so I just think this opportunity could really, just expand, what we're able to receive and be able to, confront these, these overdoses here in our community for both meth and fentanyl. And like Ashley said, meth is actually, we have higher numbers. It just continues to be overshadowed by the opioid epidemic. So we'll continue to work on both. And like I said, we'll be having some additional meetings in the community to try to bring these law enforcement agencies along for the support.
Okay. How can the Public Health Advisory Board help in this effort? Is there something that we can do for pushing?
I would say if you guys are on board with utilizing ODMAP, then submit an application, and then you can have access to the data right after your application is approved. Obviously, it would be beneficial for you guys to have, your own access. That way, when we do go to, fire or other EMS or law enforcement agencies, we can say, public health is collecting this data. This is why they need this data from the in-field personnel in order to show, your community, your stakeholders, the, board of supervisors, the state, why this information is important. So yeah, it would be beneficial for you guys to be on there for sure.
So I think I'll reach out, I don't know if Dr. Kasiri is still on, but somebody from public health leadership over there and see if public health can submit the application. Certainly my unit, substance use prevention and treatment, will be submitting an application. In regards to the funding question, there's no funding needed right now if the information is inputted manually by these law enforcement agencies. But I will research all of these companies, biospatial, first watch image trends that Ashley mentioned, just to kind of check on the option of the API and see if, what option is going to benefit our community the most as we continue to present this to various forums. So again, the potential for funding 2,000 to 12,000 or whatever Ashley said earlier, is a potential, funding need in the future, but we're hoping through the manual process that there won't be a fee tied to it. And I think just, I'll reach out, like I said, to leadership over in public health to see if we can at least get our departments, in the system, and at least we'll get some spike alert information. We'll have access to who is inputting the data, which is more than we're getting now.
Sure, we'll definitely work together on this.
That sounds great. And I'm very interested in the means of disseminating the information that will actually be coming in real time. to the community-based organizations so they can also help in these efforts to to identify and be aware of and hopefully intervene with different communities that are affected and prevent further overdoses. And I have heard that some of the community-based organizations are asking for more police involvement in terms of going after dealers. And I don't know, maybe that's a whole separate conversation, but that's a little, that's another advantage of this system, that the law enforcement can identify areas and possibly increase policing to intercept any dealers, because it's, stemming the flow is an important aspect here. But this is great. It sounds really promising. I'm so glad that that we can get involved in it. The county can have access to this information. Lori, thank you very much for bringing it to our attention. But I think I speak for the board. We're very encouraged by it and hopeful because the drug situation in our county is very, very severe. Enough is enough. And I know, Lori, your substance use and prevention treatment department is doing great work, and we want to help in any way we can. So I'm glad we could hear this, and I will definitely pass on our thoughts to the Board of Supervisors.
Thank you, Farla. And if I can get back on the agenda for the next meeting as a standing agenda item report out, I will give updates frequently as we continue to work with Ashley and her team on moving this forward. So I'll make sure that the Public Health Advisory Board is up to date.
Thank you very much. And yes, you will be back on the agenda next month. Are there other questions before we move on? No. Okay. I'm glad we had this opportunity. Thank you so much. Thank you, Ashley. It's great to hear about it, and continued success in this program.
Thanks. Yeah, thank you guys. It was great. I'm gonna hop onto another meeting, but let me know if you guys have any other questions. Feel free to email me. Lori has my email. So thanks, everyone.
Thank you. Okay. Bye. So the one last bit of business on the agenda is a FAB update. I just have a couple of things to let you know about. There will be an email coming out to the members about polling versus times and days that people would like to see as potentially different meeting times. We'll see how that goes, if we can find a better time where we can get more space for our meetings and include a youth member. So that'll be coming. Please, please fill it out. That'll be great. I wanted to let you know that there are interviews starting for the Director of Health Services position. And if you have thoughts about the candidates, what specific aspects of qualifications you would like to see in an appointee, please let me know. I actually am on the interview panel, so I would like to hear from the members what you think is important for our county in a new director, and please do that as soon as possible because the interviews are starting soon. That'll be great because I know Dr. Damiano is juggling a lot of balls in the air and doesn't have the bandwidth even to, I mean, obviously to come to us, we're not a priority, but she's been sending our updates and working very hard. And so it'll be great. They're also doing interviews for her position in primary health. So it's very encouraging, although as you can see from her report, there are still within that department, there's still a lot of vacancies around correctional health, which I know is just impossible. They've been doing everything they can, but so they could use a new director for that position. I think that's about all I had right now. There's a lot of other aspects that I will let you know about at the next meeting. But any questions, any comments about any of that? Nope. And are there any comments from the public? We have public comment period, usually during the meeting, but also at this time. No? Okay. Well, as always, please let me know if you have any thoughts, and I will see you at the next meeting in October. Thank you very much. And thank you again, Lori and Rich, for attending. Great to have you.
Everyone.
Thanks, everyone.